when I was an intern looking up and watching chief residents do this, and I was terrified. All right. So the only disclosure is that I'm not yet an expert in transplant surgery, so everything I talk about is somewhat my opinion on the current state of things. So I apologize to Dr. Perez if I overstate myself a bit. But I want to start off, I think I'm a little bit more of a quiet, reserved person, and I think a lot of people here don't know a lot about me, so I figured I'd take a few minutes and just talk about my path here and where I came from and kind of what brought me to UC Davis, what brought me into surgery, and then just piqued my interest in transplant surgery. So I was born in Sarasota, Florida. It's basically right here on the southwest coast of Florida. Literally grew up 5-minute walking distance from the beach. Those are pictures from Siesta Key Beach. So if anybody has an idea or any questions about where I got my laid-back personality, it's right there. Grew up gravitating towards sort of like the extreme water sports, unconventional sports. I did a lot of sailing. My dad's from New England, from Boston, and grew up sailing his whole life. My grandfather's a famous sailor. I think the first time I was in a boat, I was a few months old, and the first time I sailed a boat by myself, I was 6 years old, and the first time I started racing, I was 8 years old. And then sailing wasn't enough, so I got into kite surfing too. Those are some pictures from back home. And then this is, I put this in for Dr. Cantor. This is the famous intern sailing trip. So after your intern year here, all the interns get the same week off. So a bunch of us chartered a sailboat in Florida and sailed down the coast. So that's Miami right there in the distance. And then about 10 o'clock at night, we took a left turn and headed off into the Atlantic Ocean overnight and ended up in the Bahamas about 5 in the morning. Almost missed it, thanks to Kate. Well, she saved the day. And then, so from there, I went and did my undergraduate at Brown University and majored in biochemistry. And I was also on the sailing team there. We had a pretty big varsity sailing team. My last year of college, actually, these photos are from the national championship, which I ended up winning. I was on the All-American team. There's some more photos from that. And then people always used to ask me, why didn't I go into professional sailing? Is there professional sailing? There is, and 2 of my friends from college actually did, and this is them, some recent photos from them. They formed a sort of group, and they just completed their second race around the world. It's called the Volvo Ocean Race. It's probably the second most famous sailing regatta or race in the world. This is them in the Southern Ocean, which is basically right above Antarctica. These boats go like 45 miles an hour, and it's, sub-freezing temperatures. It's pretty crazy. And this is them rounding Cape Horn. Cape Horn is the southern tip of South America, and that's kind of like the Mount Everest of sailing. So they were the first boat in the race to get around Cape Horn, and then unfortunately 24 hours later they lost their whole mast and had to cut it away from the boat. And then they had to motor into some tiny little island off the coast of Argentina. They found just some scrap metal and jury-rigged the sail, and then they sailed over to Brazil, and then they had their boat reconstructed and then continued the race, which is pretty crazy. So while they were all doing that, I, after college, went to, did a 1-year fellowship at the NIH. I worked in an X-ray crystallography lab, doing protein structure and biophysical dynamics on the inflammatory cascade involved in innate immunity, which is I've always had this interest in immunity, which probably preceded my interest in transplant, but is very, very relevant. From there, I went to University of Florida for medical school, and my first day on 3rd-year rotation on surgery was transplant surgery. And this Dr. Zendejas was the head transplant surgeon at the time. And he was the coolest guy. I thought he was so much energy, so charismatic. He was so nice to the med students. He never slept. He was just always really energetic. So I really gravitated towards him. And then Mike Hong, if you guys remember, Mike was vascular fellow a couple years ago. He was the first surgery resident I ever met on transplant service. So my first day, I walk into the operating room, never been in the OR before, it's like halfway through my third year, and it's Dr. Zendejas and Mike doing a donor nephrectomy for a live living donor kidney transplant. And I walk in, and they're like, "Oh, great, med student. Why don't you grab that box over there and just take it over to the other OR?" And I was like, "Okay." And it was the kidney, and I was, that was like literally the first thing they said to me, and I was just kind of in awe, and thought I was like in shock that they were letting me do this, and then I started thinking how terrifying it would be if I dropped it or stumbled or anything. So I'm walking out of the door, and if you all know Mike, this is how I know it was him, because what he said and his little chuckle afterwards. But he's like, "Hey," and I stop, I turn around, and he's like, "If you drop it, just don't tell anybody about it." So I didn't drop it, but the transplant went well, and the next day, it was a daughter donating her kidney to her father, and everybody's emotional and crying and hugging and just profusely thankful and grateful to us. They thanked me for some reason. And it was just that whole like 2 weeks on that service was just incredible, and that's really the reason why I went into surgery and really started my interest in transplant surgery. So from there, I met this guy, or I had some connections, knew this guy, and then by the graces of all three of them, I was able to come here, which I'm forever grateful. And then once I came here, my interest in transplant just continued. I had an incredible experience. Dr. Perez has been an incredible mentor and role model for me. But then, Dr. Krishnan, Dr. Calhoun, Dr. Trotman, Dr. McVicker, and Dr. Sagashima have all been great resources for me in trying to figure out my life in those last couple of years. And so next year I'll be going to UCLA for a transplant fellowship, where I'm told I might be one of the last fellows to train under Dr. Busuttil, which I'm pretty excited about. There's kind of a crazy moment when I was interviewing there, and you hear all these, Dr. Busuttil is kind of like a legend, and you find yourself in his living room drinking a beer and hearing him talk about how he started the transplant program like 40 years ago. It's just kind of it's pretty shocking. So excited about that. So now I'll get into the meat of everything. Going to talk about the organ shortage, which is the big pressing issue in transplantation today. The outline, basically 3 different general categories. It'll be try to be kind of broad overview of everything for general audience. So I'll talk a lot about some statistics behind the organ shortage and the gap between the supply and the demand we have right now. Then sort of strategies that have evolved over the last 10 years or so, and different efforts that we've made to try to bridge the gap. And then last, I'll talk about something that's a little dear to me and Dr. Perez, which is the hot new topic of warm perfusion for recovery and preservation of organs. So this is sort of a famous slide from the UNOS that's been around for a few years. It's pretty demonstrative. To me, it shows you aren't dealing just with a shortage, but this is a crisis. The top line there shows the patients waiting for, this is all organs. And then the bottom 2 lines are the number of transplants and donors recovered every year. So that gap is huge. And I mean, overcoming that seems like a monumental feat. And then when you look at kidneys alone, this is from the Wall Street Journal a few years ago, but it's still relevant. The gap in kidney transplantation is particularly wide compared to all the other organs. And the growing demand for kidneys transplantation is really driving this gap. So this looks at, I pulled all this data from UNOS, which is huge, it's easy online data that anybody can access. So looking at liver transplants and kidney transplants, this depicts the people added to the liver and kidney waiting list each year, as well as the number of transplants performed for each organ each year. So not only is the accumulated number of patients on the wait list outweighed by the number of transplants each year, but the new additions each year are far exceeding the number of transplants performed, almost twofold. I think this is pretty impressive slide to me when I was making it because, I mean, just think about it. There are twice as many people are getting added every year as transplants are being performed. So you have to consider all the people basically are coming off the list, dying on the list, or being removed for medical or social issues as well. But this is pretty impressive to me. Then if you look at deaths on the waiting list, they're pretty impressive as well. At least with liver transplants, we're kind of heading in the right direction, and heart transplants have been kind of stagnant. The kidney curve is interesting. I had to actually talk to a couple people to interpret that. But what we gathered was this inflection point here probably represents just the growing demand and rise in people listed for kidney transplants. And then here, everything was overwhelming. And centers got more aggressive, policies changed in organ allocation, and people got more aggressive about delisting people who just have no chance of getting an organ. So that's kind of really shows how overwhelmed the system is in terms of the demand. And then in 2016, there was President Obama had a summit for the organ crisis. He said, America's progress in science and technology has countless revolutionary discoveries within our reach. New breakthroughs in treating cancer and ending the wait for organ transplants. That's some of what America can do. What's interesting is, or what's notable about this is Dr. Perez was actually invited to the White House to report on our experience here because how impressive the dramatic, the progression in our program has been in the last 15 years or so. I don't have that picture of Dr. Perez at the White House. I was trying to find it online, but he does.
We'll get it for you.
Yeah.
We have
it. So how do we bridge the gap? I'll talk about a few of these, or all these topics. Living donation, first off. There have been a lot of efforts over the years, particularly in kidney transplantation, improving access to living donors and outreach and educating the community about the benefits. Then the bulk of what I'll be talking about is unconventional donors, because this is, where we're probably going to get the bulk of our organs is just looking at organs that we've not typically used in the past and trying to find ways to use them, better assess them. So really being more vigilant and aggressive about using some of these organs we haven't used in the past. It includes small pediatric organs, donation after cardiac death or circulatory death, which I'll talk about later, and then marginal donors in general, which usually is older people with comorbidities, maybe some and organ dysfunction as well. And then I won't talk about xenotransplantation, but it is a thing. There's been talking about this for decades, there's one transplant surgeon who used to be at Indiana. His name is Joe Tector. He's now at UAB, and he is pretty aggressive. Feels pretty strongly about xenotransplantation. My co-fellow next year actually did a lot of research in that at Indiana, so he's a firm believer, but I didn't hear many people talking about it on the interview trail. And then I'll talk about normothermic perfusion and emerging organ assessment strategies at the end, which is really where I think the future is going. So in living donation for kidney transplantation is clearly the optimal choice for graft outcomes. Outcomes for recipients are better across the board. Morbidity to the donor is very, very minimal. And this is key. So considering living organ donation, the morbidity to the donor is paramount. We're very sensitive to any morbidity to donors. So you can see living donation for kidneys comprises roughly 30% of all kidney transplants now. And this is data I pulled directly from UNOS. So you can see a steady rise since 1990, and it continues to rise. Just a few years ago, the chair of kidney transplant at Columbia gave a good lecture here about some of the outreach they had in their local community with the African American and Hispanic communities to basically increase awareness for living donor transplantation and sort of mitigate some of their concerns and fears. and they had a huge improvement. For livers, the experience in the Western world is lagging when compared to kidneys. There's a number of factors that relate to this. You see, is not as predominant and has had some setbacks over the years. Interestingly, in Asia and overseas, it is actually quite common. It is the preferred source of livers. We had an uptick, just before 2000, you can see there, and then some bad outcomes and some more awareness of some of the morbidity related to that the donors incur, I think kind of caused those numbers to trend down. But it's coming back, and it's steadily rising over the last few years. Specifically, when you look at some of the outcomes and problems with living donor liver transplants, the main benefit to a living donor liver transplant is with these low MELD recipients. These patients, it's hard to, the system favors the sickest first patient. So if you have a low MELD, say you're a patient with primary sclerosing cholangitis, you're not that sick yet, your MELD's in the low teens or 10, you're going to need a liver, but in California, the average MELD for a transplant is in the mid-30s. So I even heard when I was interviewing that UCSF tells these people to just go to Arizona because there's just no chance they're going to get a liver here, unless you do a living donor liver transplant. So that's the main benefit for living donor liver transplants, is getting those people livers before they get too sick. But you see here, some of this data is a little old, but the complications related to donors are pretty high. Biliary leaks at 8%, hernias, unplanned explorations, infection rates. And that's the donor. When you look at, for our kidney transplant patients, it's basically if they don't stay longer than 2 days and don't go home with any complaints, so that's like a failure. We're pretty sensitive on our outcomes for the donors and kidney transplants. So that's a lot. It's a lot more to donate part of your liver, and that's the other thing is adult to pediatric patient might donate their left lateral segment, which is a little less morbid. But if an adult to adult, sometimes you take the right lobe, and that's incredibly morbid operation. And then on the left here, some of the outcomes you can see compared to deceased donor transplants are the complication rates are higher. And this is, again, it's a little old. And as living donor transplants are rising in the U.S. and people are getting better at them and centers are becoming more experts at it, then some of these numbers have decreased. But still, it hasn't become as widely adopted. So next, we'll talk about pediatric kidneys, pediatric donors, mainly in kidney transplants. So recovery and utilization of pediatric kidneys has grown tremendously since 2005. I'll explain a little bit about why that is in a bit, but the rate of discarded organs is still quite high in this group. Recent reviews show 54% of organs recovered from donors under 10 kilograms, 54% recovery rate from donors under 10 kilograms, and 30% of those are being discarded. And that doesn't even account the organs of potential donors that we're not even considering or looking at. That's just the organs that are being recovered. Plenty of the organs that are recovered, that are discarded, are not even considered, or probably offer some valuable use. Why do people shy away from these? Historically, there's been a higher incidence of complications related to vascular complications, ureteral complications, and higher episodes of rejection. They are technically more challenging, but when considering when you're considering these very young neonates, there's a huge cultural and emotional barrier to discussing donation with these parents in the neonatal ICU. We're trying to overcome that. So pediatric kidneys can be transplanted en bloc as 2 kidneys, or you can transplant them as 2 separate kidneys, which is ideal if possible, because then you're helping 2 patients out instead of 1. The considerations against splitting grafts are the risk of hyperfiltration injury, which is basically a mismatch in the perfusion pressures and whole blood, the perfusion to a small kidney and with immature glomeruli when you put it in an adult. and there's an increased rate of vascular and ureteral complications. But looking back historically, you can see that the outcomes are pretty poor in the 90s. There's a study there, 48% graft survival for donors under 22 years old, then 69% in another study later on for donors under 2 years old. But then in 2004, there was a pretty big study that came out where they took kidneys over 6 centimeters and they had pretty good outcomes. And that kind of correlates to when you see that uptick right here in the number of young kidneys recovered. The other thing that helped improve these outcomes over the years was improvement in preventing rejection. They had a pretty high incidence of acute rejection back in the mid-90s with these kidneys, and they saw that better drugs came around and were better able to treat rejection and sort of prevented some of those issues. So this is our experience that I had written up in my research here. This is our entire review of small pediatric kidneys transplanted as a single kidney. This is actually, when I looked at it, it was the largest series reported for kidneys from donors under 20 kilograms. You know, most people feel comfortable splitting the kidneys when the donor's over 20 kilograms. But there's not a lot of science behind the decision-making process. So we looked at our outcomes and showed that you can split these kidneys at younger weights or lower weights and have good outcomes. We found that even under 15 kilograms, we had good outcomes, though worse than the ones between 15 and 20. You do have a slightly higher complication rate, but overall the outcomes are great. And then this is the neonatal project that I've been a part of. So Dr. Perez has been very eager at looking at neonatal donation. And as I talked about earlier, there's many barriers in terms of emotional and cultural issues related to neonatal donation. The technical difficulties are also real as well. But Dr. Perez spearheaded this project years ago, and we ended up getting 28 transplants from neonates ranging from 1.9 kilograms to 5 kilograms. Just so everyone appreciates how remarkable this is, there are only 2 other series that I know about in the world where they talked about neonatal donation, and the series numbers are far less than this, you know, in the single digits. And when I was on the interview chair, I told people that we transplanted a baby, kidneys from a baby from it was 1.9 kilograms, and people were just kind of shocked. But that patient is actually one of the best in the series in terms of graft function. So now we have 5-year data, follow-up data from all these kidneys, and the outcomes are pretty remarkable. You see, there's early on, we have but we have some complications and impediments in terms of, most of that's either primary non-function, which means the kidneys just don't work right away for whatever reason, and the others are vascular complications and thrombosis. But once you get past that, these kidneys, you don't see many complications. Their graft function is incredible. I mean, a curve like this in kidney transplantation is pretty remarkable. You're seeing graft improvement or function improvement 3 years out. You know, you don't see that in any other deceased donor transplants. So next, marginal donors. I alluded to this earlier. These are the organs that, from unconventional donors with some medical comorbidities, DCD kidneys, which I'll talk about in a second. Arguably the biggest impact we can have on improving utilization of an organ supply is with improving our utilization of these. These organs are, you know, from non-ideal characteristics, a kidney from a 65-year-old with diabetes, or liver, a kidney that was recovered from after circulatory death as opposed to brain death, hepatitis C positive donors. Historically, surgeons have shied away from these because they do carry well-known risks, but in the area where people are dying from this organ shortage, we have to be innovative and take some calculated risks. So this is, Dr. Calhoun pointed this article out to me a few months ago. And this is kind of a little segue, but this is a big series from biliary complications and liver transplants at UCLA. So I was interested. I read it. And their conclusions basically were, they found, not surprisingly, some donor factors and recipient factors that were significant and predicted some bad outcomes in terms of the biliary complications. And they proposed, we be a little more careful about considering donor characteristics and donor factors when matching to recipients. Seems reasonable. And then, this is like on the cover of JAMA Surgery Online, and I hope Dr. Khan doesn't, I hope I don't misspeak on his behalf, but he wrote this invited commentary, and I thought it was really poignant and relevant to the rest of my talk, so I quoted it. He said, the ongoing shortage of available organs, allocation disparities, initiatives to encourage the use of more marginal allografts, expanding indications, and increasingly high acuity patients are pressing realities. The authors opine that the ever-increasing acuity of transplant recipients limits their tolerance of such postoperative biliary morbidity. Unfortunately, it is that same acuity that pressures the use of more marginal grafts. Despite any positive effect of looming changes to organ allocation, the organ shortage will persist. To appropriately act on the advice of this original investigation will require fewer heroics and more healing based on the true heroes, donors, and their families, both living and deceased. So essentially, we're in the midst of an organ crisis, and we're desperate for organs, and we're taking what we can get, and we need to be more innovative and take calculated risks to save lives. So donation after circulatory death. This is one area of focus in the past couple of decades that has really expanded the organ supply, and it's the use of the organs from donors who are not brain dead at the time of recovery. So especially with kidney transplantation, donation after cardiac death has had a tremendous impact on the expansion of organ supply. But as I'll address soon, there are some limitations and controversy with their usage, especially with liver and heart transplants. So just to review what I'm talking about, the brain death operation for your standard organ donation, you perform a laparotomy, sternotomy. You inspect the organs for any obvious signs of any reason why you wouldn't use them, or there's evidence of malignancy or whichever. You do a Talbresh, mobilize all the way to the left renal vein, isolate the IMV, cannulate this. There's pre-cool perfusion that I think is only done at UCLA, but put it in here. And then you cannulate the infrarenal aorta. You do a portal dissection, divide the common duct, flush the gallbladder out, get the bile out. Then you clamp the supraceliac aorta, and then you cut the right ventricle or the IVC, and you just flush everything through the aorta and the IMV. For the DCD operation, you withdraw support, meaning you extubate the patient after you prep and drape. Then the surgical team usually leaves the room until the anesthesiologist or someone declares death. Then there's a 2-minute, depending on what state you are in, 2 to 5 minute grace period where you can't do anything until you make sure the patient's dead. Then you perform a rapid laparotomy, get the infrarenal aorta out, cannulate it, and then you just start flushing immediately. And then you go and perform a sternotomy, clamp the supraceliac aorta, vent the IVC, and then you can perform your cold dissection. I put it in the bottom there. At Wisconsin, I read that they do they cannulate the femoral vessels early on before, so then you can more rapidly flush, but I'm not sure. Dr. Perfusion. Yeah. So this is just some images depicting what I was describing here. So you can see the cannula and the infrarenal aorta, and then the cannula and the IMV there to ensure that you're flushing the portal venous system and the arterial system. So this shows recovered organs from after circulatory death over the years. You can see it started off in the mid-90s, but really didn't pick up until after 2000. And it's between livers and kidneys, it's really a tale of two stories. DCDs for kidneys have become mainstream, widely adopted. It's, the use of them is just growing rapidly. But for livers, it's been a mixed story. I think there's an uptick you can see there in the early 2000s, but it tapered off because some bad outcomes realized they're not quite as robust, and they don't recover as well as the kidneys will. So look more specifically on some of the issues related to DCD organs. You basically incur this period of warm ischemia, which is the whole controversy behind using them. So it's important to know there's people define the ischemia time at different points, right? You can define it as when you withdraw therapy, which is here is depicted as the total warm ischemia time, or you can define it as when either the pressure drops below 50 or the pulse ox drops below 70 or 80. So I think that this what's here is the true warm ischemia time is probably better reflects the warm ischemia the organ is incurring. And you can see there's some listed times that are sort of generally accepted when considering using these organs. The liver tolerates less warm ischemia than the kidneys do. Yeah. So like I mentioned before, I'll just say a few comments about DCD kidneys because outcomes have been excellent and it's become mainstream. With appropriate selection, meaning consideration of donor characteristics, biopsy results, warm ischemia times, these organs will do well. There's a higher incidence of delayed graft function, which means the patient needs dialysis to bridge them until the organ recovers from the ischemia reperfusion injury. But ultimately, they recover and they work well. As well as like a living donor transplant or an ideal brain dead donor, but they do quite well. The unique thing about kidney transplantation that really provides a lot of flexibility in using these is that we have dialysis. So you can use that as a bridge to recover from the injury that these incur during the warm ischemia time. And that provides a lot of flexibility. As you can imagine when you're thinking about heart transplants or liver transplants, you're not really afforded that. There is no dialysis for livers or you can't keep the patient on ECMO for weeks. So, or maybe you can, I don't know. So that really is the limitation, or one of the limitations in using them for other organs. So when you look at this, I think some people might say DCD livers aren't a controversy because they just don't work well. There's no controversy behind it. But it's had a rocky growth over the years, and outcomes are clearly worse compared to brain dead donors in terms of complications, morbidity, and graft survival. Graft loss and mortality are almost twice that of brain dead donors in some studies. And the biggest non-fatal complication is ischemic cholangiopathy, which I'll talk about in a second, which can be up to 50% in some studies when they look at DCD livers. On the other hand, there are some studies showing good outcomes with some appropriate selection. There's a study in 2011 from the Mayo Clinic that showed no difference in graft and patient survival when they matched them to brain dead donors. And a 2006 study showed appropriate acceptable outcomes with comparable rates of ischemic cholangiopathy as well. So it's a mixed tale. Ischemic cholangiopathy, call it the Achilles heel of DCD liver transplantation because really the bile duct incurs that ischemic injury after that period of warm ischemia, and it's hard to recover. I always think of the biliary anastomosis and biliary complications are comparable or commensurate to the ureteral complications in kidney transplant. So when you're doing a kidney transplant, you reperfuse the kidney. Everybody's so intense on sewing it in as quickly as they can, reperfuse and making sure it doesn't thrombose. And then you kind of sigh, you have a little period of relief, and you're like, okay, all I have to do is the ureter now. But really, the ureter can be one of the hardest parts technically, because you don't see the complication immediately. It's down the road, and then if you screw that up, then you're giving that patient months of interventions and nephrostomy tubes and potentially retransplant. So I think especially as a resident's going through, you kind of overlook how significant that is. And it's the same thing with the liver transplant. You perfuse the liver, you sew it in as fast as you can, and then you think, all I have to do is the bile duct. And the complications related to the biliary problems in liver transplant can be huge, as you can see here. On the left is immediately a cholangiogram at the time of transplantation, and then the next one over is some follow-up. And that was within 1 month of transplantation. You see some focal areas of stenosis, and then later on you see it's just diffusely ectatic, and then the patient ends up needing a liver transplant again. And this happens within 1 or 2 months. So you would think that there can't possibly be a role for heart transplantation using DCD to hearts. Basically, the patient has to die from ischemic injury to the heart, right? The heart has to stop before you recover these organs. But only a few cases a year in the U.S., but more common overseas. And there's a bunch of studies out there, and this is just one I picked. They looked at brain dead donors versus DCD donors in heart transplants. This is in the UK. I remember what's notable about this, and they showed comparable graft survival rates and patient survival rates. But what's notable is the way that they had recovered these DCD hearts is really interesting. And I was first introduced to this when I was at the transplant conference, sitting next to Dr. Perez in Chicago. And I was taking a little mental respite, but he kind of nudged me and said, "This is some crazy stuff. You got to look at this." And so I started paying attention. And their protocol, basically, you do the normal withdrawal support, extubate the patient, give them their obligatory, the patient dies, you wait the 2 minutes, then the anesthesia teams reintubates the patient, puts them on the ventilator. At the same time, the cardiac surgeon does a sternotomy, cannulates the great vessels, and puts them on ECMO, but then has to occlude the carotids to ensure that you don't reestablish cerebral blood flow, so the patient stays brain dead. And then you then you revive the heart, and then you have basically an in vivo model of function of this heart, which is crazy. But they think they are. The guy giving the talk was I think he was either from Cedars-Sinai or USC, but it seemed to be pretty routine practice from what I read over in UK. Yeah, it just shows you the measures that we're going to try to get more organs and solve the crisis. So then the art of organ selection. I think I coined this term, but maybe it's been around before. But this is just what I've picked up being on the service for so many months, and listening to Dr. Krishnan and Dr. Perez take organ offers and figuring out why they decide to use an organ that nobody else will. And then it works, So when we assess organs for transplant, you assess the donor characteristics, mechanisms of death, the state of the donor, the kidney function or liver function, biopsy results, the overall appearance of these, especially livers. You look to see if it's a steatotic liver or not. And then this leads to a decision based on your estimated probability of this organ will work. There's some science behind, we know high warm ischemia times, a certain threshold are not going to do well, but there's not great scientific, like a calculator you can put all this stuff into, and that gives you a straightforward answer. There are indices, particularly in kidney transplantation. There's an index called the Kidney Donor Profile Index, which uses donor characteristics to come up with a prediction model. And that a lot of people use that, or pretty much everybody uses that to guide their decision-making process, some more than others. But using that alone is not, would exclude a lot of kidneys that would be viable. When I looked at our kidney transplants for these high-risk kidneys, so this is the KDPI, the index I was just referencing, goes from 1 to 100. The 85 to 100 range is considered the high-risk kidneys. And some people won't even transplant them, I believe. The discard rate for those are over 50% in some studies. So we looked at how many we did here over several years, and we did 93. The average KDPI for them was 91. And the expected 2-year survival for these kidneys, if you look at based on the index, was 79%, but we somehow were able to achieve a 91% survival rate. That would include, censored for people who died with functioning grafts, however, but still better than the expected outcomes. So I just wanted to bring up a couple more anecdotes to drive the point home. These are a couple examples of kidneys that I've either been a part of or observed when being on the service. Both of them happened to be with Dr. Krishnan, but that's just kind of coincidence. He had a 21-year-old trauma patient from a car accident who, was on ECMO and hemodialysis at the time of recovery, and nobody wanted these kidneys. But because he's a young donor, healthy kidneys, no medical comorbidities, we expected him to recover from that injury. And ended up taking them. The kidneys did well. The patient was on dialysis for a few weeks, but recovered, and they worked well. Then, just from a couple weeks ago, or maybe a couple months ago, I walked in the OR and there was a 20-year-old donor, DCD donor, and had 50 to 60 minutes of warm ischemia time from the East Coast. Nobody wanted it. We turned down everywhere, but we took it, and both the kidneys worked. I was in the OR and they made urine on the table. So there has to be a more scientific way to discern organ viability, and these organs would have been discarded otherwise. Instead, we changed 4 people's lives. So how many more livers or kidneys are out there that we're not seeing, that are not being recovered because the perceived risk is too high? And the big question is, how do we transition from the art of the selection process to a more scientific selection? And this is the answer. Ex-Vivo Normothermic Perfusion. So many propose this is the answer, and I'm drinking the Kool-Aid. Essentially, you hook up the organ to an ECMO circuit, and you perfuse it at warm temperatures. And this enables you to, assess the organ's function in a model that simulates the in vivo physiology. But it also, we haven't yet shown definitively that this provides a means to recover the organ from ischemia reperfusion injury. And especially when you talk about liver transplants, that would be the biggest benefit, because like kidneys, you can transplant them and put the patient on dialysis and you have a bridge. But when you talk about livers, you really, the effort is to try to mitigate that period of early graft dysfunction, because otherwise it's not viable. So I'm just gonna go through a few studies that came out regarding this. This technology really came about. Heart and lung transplants had an earlier adopting of this, and a lot of the pioneering work was in that, but I'll talk about kidneys and livers a little bit more. And a lot of this stuff was done in the UK. They're very far ahead of everybody else. So this is the pilot study that was done by Dr. Hosgood and Dr. Nicholson. Dr. Hosgood actually came to UC Davis and kind of introduced some of this technology to Dr. Perez. So they did 6 pigs, randomized, to cold storage, which is the conventional means of organ preservation. You flush it with University of Wisconsin solution and leave it on ice, versus a period of cold preservation and then a short period of normothermic perfusion, just 1 hour. And this is basically just to assess the organ, not really, although the goal wasn't necessarily to recover it in that 1 hour. And these are their initial outcomes. So you can see the ones that had cold storage. They both had peak serum creatinine levels, but the one that was perfused in the warm circuit showed an improvement in creatinine down to baseline. And this really just showed that they could do it. And then they tried to do it, and I would be remiss if I didn't talk about our experience a little bit. So we tried to reproduce their model with a longer period of normothermic perfusion. And though we did have some problems down the road, our initial outcomes, these are from our first few transplants we did that were successful. And the blue lines there represent a cold storage kidney and then a cold perfused kidney. And then the bottom line is the warm perfused kidney. So there's just 3, and then we did have some problems after that, but we did have some initial promise. So does it work in humans? And the same group in England did this study where they took a set of kidneys from a non-ideal donor that was turned down everywhere else in the UK. And then they transplanted one of them after cold storage and one of them after 1 hour of warm perfusion. And you can see here the one on so the bottom curve here is the warm perfused kidney. Didn't need dialysis and stayed off dialysis. The other kidney, all these points here reflect times when the patient needed dialysis. The patient needed dialysis, had delayed function, ended up coming off dialysis, and the kidney worked well. But you can see the outcomes are better with the warm perfused kidney. This is 1 patient or 2 patients, but showed some promise. And there's some more studies out there, lots of studies. Clinical studies mainly in the UK. There haven't been any clinical studies that I know of in the United States yet in terms of kidney transplantation. But there is a randomized controlled trial now in the UK using this technology by the same group of people. And I don't have any outcomes from that yet, but this is, huge, huge study that could have dramatic implications. So when we talk about normothermic perfusion and liver transplantation, I think this shows the greatest promise for this technology. With the increasing age of donors, increased obesity, increase in undiagnosed hepatic steatosis, there is a clear need to assess marginal grafts. In addition, the increased pressure to use marginal donors and DCD donors. In the UK, it's up to 20% of the livers recovered are DCD. Normothermic perfusion has tremendous promise and to aid in the assessment of organs and then potentially mitigate ischemic injury. Like I said before, the emphasis on normothermic perfusion has been primarily in liver transplantation rather than kidneys. I cited all this work on the kidneys. The liver work has preceded that a bit, and a lot of the emphasis has been with livers primarily because of what I mentioned before. The kidneys can tolerate a little bit of graft dysfunction, and the patient can be bridged with dialysis, whereas in liver transplants, you don't have that same luxury. And the goal would be to really prevent any ischemic, well, obviously assessing the liver for transplant viability, but then mitigating any of that reperfusion injury that the patient would incur after a reperfusion. So this is one of the devices. It's a portable device, completely like self-sustaining. This was developed by a group in England for livers. As you can see here, they cannulate the hepatic artery, they cannulate the bile duct, they cannulate the IVC and the portal vein, and it's a complete closed circuit. It is literally transportable. You take it to the recovery hospital. You can put the organ directly on the pump, transport it back to the recipient hospital. You can perfuse an organ up to 24 hours. So it's pretty revolutionary. Today there are 4 devices like this on the market, or not on the market, but in studies. There's this one. This is from the British group. There is a device from Transmedic, and I think that's from the group from Mass General. And then there's the device from the Cleveland Clinic that I read this review, and it had all this data on all the other devices and their designs and stuff, and then the Cleveland Clinic model just said nothing. They said it's all proprietary and they're not releasing any information on it. They're not letting anybody use it. But all the other groups are collaborating, and there's the Dutch have their own device as well. This is just a schematic of the OrganOx machine. You see there's a reservoir for the portal venous blood, and then blood circulates through a centrifugal pump and an oxygenator to supply the hepatic artery. Cannulate the bile duct, so you drain bile. You can infuse bile salts back into the system, as well as insulin and nutrition, and prostacyclin is a vasodilator. And this, as I said before, you can run this thing up to 24 hours. This was one of the first studies, clinical studies, in using this particular machine, the OrganOx machine. And it was a non-inferiority study. It wasn't piloted to show a huge difference, but they showed equivalent outcomes when they matched outcomes to donors to other deceased donors previously transplanted. And the only significant thing they showed was a lower peak AST after transplantation. But it basically showed that this is feasible, and this led to what's happening now, which is, kind of end with this. So this is, in the next few years, it's going to be pretty huge, I think. There's 2 giant randomized control trials going on in the U.S. These are the first clinical trials with this technology in the United States. And like I said, the Transmedic group is the one, I think it's from Boston, and they're accruing a goal of 300 patients, and they're taking high-risk organs. They're not taking the ones that generally do well, but these ones that I talked about, the marginal donors, the DCD donors, and randomizing them to cold storage and normothermic perfusion, and looking at basically early graft dysfunction and graft survival. I listed all the centers there that are involved in that, and there's a similar study with the OrganOx machine here. When I was asked a lot of people when I was interviewing about how it works and how it's been going, and it is quite tedious. It requires a big team because you take this giant thing to the recovery hospital. You have to do an extensive back table dissection of the liver, put it on the pump, and then you move it transport back to the recipient hospital. But some of the guys say you take the DCD liver that normally reperfused and looks terrible, and then when they use this, the organ goes on the pump right away, so you're kind of avoiding a period of cold storage, and it's being perfused in the warm circuit the whole time, and they reperfuse like perfect organs. So there's no data yet, but I think in the next couple of years it's gonna be pretty dramatic. And that's everything.
Well, Dr. Perry, first I want to say thank you for not drowning any of my interns on that trip between the years. I appreciate your expertise there. And we've got a few minutes for questions about this incredibly provocative presentation. I'm not surprised that this is a place that inspires people to go into transplant, because it's certainly been a place that has been a leader in thinking about creative ways to solve this problem. So we're thrilled you're following that path. The first question that comes to my mind is, why not use the Organox box for kidneys?
Yeah, that's a good. So I believe there is some technology coming down the pipeline where they're coming up with a self-sustaining device. Dr. Perez talked to me about it, but I haven't seen any literature on it yet. But the device is geared very specifically for the liver in terms of the cannulas and all the circuits and everything. But a lot of it, like I said,
it's really just an ECMO machine, right?
Yeah, well,
sort of.
I think it's more, but
well,
but it like I said, I interviewed some places and I asked, I don't know why we're not doing with this kidneys now, and a lot of people just haven't adopted the idea that this is a need for kidneys.
Because obviously the need for liver, since there's not an immediate rescue.
At least in the U.S. In the U.K., like I said, it's been the difference in the technology and the literature that's come out has been pretty profound, and I think part of that is regulatory. When we were trying to do our study, we had huge hoops. And in the UK, they didn't have to even go through their equivalent of the FDA. So regulations have been a big problem.
What gets applied to an Ex-Vivo device, and why does the FDA regulate that? And a very interesting question that a lot of us are dealing with the FDA for all kinds of issues. So. Any other questions?
I enjoy your presentation, Andrew. It's very obvious that you not only drunk the Kool-Aid in very large quantities. So, I would just encourage you, as you go on to your fellowship, to keep an open mind, because what you may think is crazy now is going to be standard of care, essentially. And I'll use the laparoscopic donor nephrectomy as an example. When we first started doing that, back in the 90s, everybody thought we were crazy. I mean, it's just, they were accused of harming the patient and a lot of different things. And now it's standard of care. So if you'll have an opportunity to see some kind of crazy stuff, it's up to you and in the future to kind of decide what really applies. And I think what applies is important that we become focused on. But we certainly look forward to great things from you and seeing you in the future at meetings and maybe other ones.
One last question.
Great talk, Andrew. I'm very excited to see where you go with your career. My question for you relates to oxygenated versus ischemic perfusion with these both warm and cool ischemia devices. Do you think that is a place that transplant surgery is going, like oxygenated perfusion during transport or water on pump versus ischemic?
You mean perfusing them without an oxygenator?
Yeah.
So, I don't know. I don't think anybody would dare to perfuse an organ under warm conditions without ensuring like appropriate oxygenation. I don't know of any. That's what you're
cold, like, right
Oh,
now
cold
it's
perfusion.
perfused, but ischemic. So is that like a place that this is going to?
I don't think people have looked too much into that. I mean, the cold perfusion is a hypoxic environment. I know that, but I don't know about any. I think people might have looked at some oxygen carrying capacities in the cold perfusion, but I don't know of any dramatic results from that.
There are a few centers in Europe actually that will perfuse with cold perfusion and add oxygen to these levels.
Hasn't there been some work with carbon and some of the other oxygen carrying?
That as well. But the metabolism of a cold organ is so low that the benefits of oxygenating really not optimal. But of course, when you warm the organ up and it has normal metabolism, then of course it thrives.
It's great. Thank you again, and really wish you all the best.